Good morning, good afternoon, and hello. This is Joe Westbrook here for vlog number 2, and my reg number is 131897. So the client I'm treating is a guy called Leonard. He's an avid university rugby player, plays for the league team, so he's quite an athletic guy already. And he is come to me with a complaint of lower back pain. The onset was about 4 weeks ago. It hasn't particularly got any worse, but maybe a little bit. And he gets referral pain into his glutes and sometimes down to his leg. He can't remember any sort of mechanism of an injury, so there was no direct tackle or direct blow, but he remembers after the game it hurt. Since then he's been using things such as ice to treat it, but it hasn't really had much effect from then. So during the objective assessment, we tested Leonard's range of motion, and we had limited knee flexion on the right side compared to the left, which brought on a tiny bit of pain in his lower back. We also had limited hip extension on that same right side, and it felt like that was a bony block. So that it had full active and passive, but it wasn't as good as it can be just due to this block. We also did muscle resistive tests and found that strength in the hip was good, but it was just the range of motion that was limiting it, so a 5 out of 5 in terms of strength. And we did some special tests as well. We found that during the stalk test, when he raised his right knee to his chest, there was very little posterior rotation of that PSIS, which was palpated on the back of him. During the Piadolou test as well, we found that he could anteriorly rotate both of his PSISs, but then when he came back up, the right side would stay in a fixed anterior position, which presented as slightly higher and forward. We also did some neural tests on Leonard. We tested sciatic and femoral nerve, and there was no positive findings there, suggesting that there's no real impingement of the nerve or any pain relating to that nerve. So now that we've got a brief background of Leonard's current pain, we're going to move on to the treatment. We're going to go on to the phase 1 local treatment, which means we treat the symptomatic tissue, and it's quite an important part of treating a client, as it gives you time to build a relationship with the client. You can show them some soft tissue treatments or whatever you choose to use, but it means that we can reduce the pain quite quickly, which means they'll build confidence in you and trust, which is very good for the rest of the treatment. I mean, if you went in with triangulation or FMR straight away, they might be a bit thrown off and might not like it. And it also gives us a chance to have a look at areas in the body which may be a little bit tight or may not be moving as correctly as they can be. But I'll explain that later when I'm treating. So, here we are, phase 1 local. The aim of this part of the treatment is to treat the symptomatic tissue, so the tissue that the client presented with pain. For Leonard, I'm going to be using some tough soft tissue treatment techniques that's aimed to reduce pain, but also give us an opportunity of a window to work in that's pain-free, using things such as the pain gate theory and neuromodulation to help. So here we are with Leonard, just going through some stripping techniques of the erector spinae. During the objective assessment, upon palpation, we found that there was tight spasm in these muscles. Therefore, using the hard bony end of my elbow, I am applying quite a lot of pressure to the erector spinae and just slowly moving my way up the back to release any tension. Okay, so now we're going to move on to some trigger point techniques. I'm going to start with getting deep into the quadratus lumborum, which is the lower back of the portion of Leonard. And we're going to base this on a VAS scale, so a pain rating 1 out of 10. I'm going to start and ask Leonard how much it hurts out of 10, 10 being the worst pain imaginable, and then he's going to let me know when it fades down to about a 2 out of 3. So Leonard, if you could tell me, out of 10, 10 being the worst pain, how this feels.
It's about 7.
About a 7, okay? So just let me know when it gets down to about a 2 out of 3, okay?
Okay.
And the aim of trigger points is just to hold on, keeping that tight pressure on the muscle. Over time it will break down, and the tight nodule in the muscle should release. It's also very good for pain gate. It sends a stronger signal to the brain, the central nervous system, which then blocks that of the pain going to the muscle. And how's that feeling now, Leonard?
Yeah, that's released now to about a 4. Quite nice. This side's quite tight.
Okay, so now we've moved on to the other side, using the exact same technique, just using my thumb to get really deep into that QL muscle. And I'm going to ask Leonard again, out of 10, 10 being the worst pain, how does this feel?
It's about a 7 again.
Okay, and just let me know when this fades off.
Yeah, that's about faded now, it's about 3.
So now we're going to do some trigger point release of Leonard's piriformis. And to find this, we just find the sacrum and also the greater trochanter. We find the midpoint and then just drop a little bit lower. And from there we can apply some pressure. And because Leonard's quite a strong athlete, we're going to use an elbow just to get a better grip on it and use more pressure. And once you've used this trigger point in this position for a short while, we can then introduce some leg movement. So we use the elbow again in the piriformis. We can then bring the knee into flexion up to 90 degrees and just initiate some internal and external rotation. So before the soft tissue treatments, no objective markers were taken, which perhaps could have been something to improve on for next time, although we did use pain and the VAS scale to determine whether any positive effects came from the trigger point release. So as a part of treating Leonard, especially more so in the phase 1 global, we want to look at the probable suspects. Now I've used some soft tissue treatments on his lower back and spine, but I want to address any probable suspects which may be contributing towards the pain. One of the most common ones is an anterior innominate rotation on one side. And this is where the innominate is fixed in an anterior position, therefore it causes pain and distress to the posterior ligaments of that sacrum or the sacroiliac joint, and it can be easily fixed using certain treatments. So to test for anterior innominate rotation, it's called the sitting line test. And normally this will present as leg longer in line and shorter in sitting. What we're going to do is we're just going to realign the pelvis on Leonard. So if you bring your knees up and lift your bum for me and give it a little wiggle. Cool. And place it down and just hold them to the side of the bed. And this is where we want to apply just some force through and give a good pull on the legs. And we use the landmarks as a malleoli. And for Leonard, you won't be able to see it on this camera, but we have a left side malleolus, which is longer presenting than the right side. Okay, and then to test if this gets shorter in sitting, we want Leonard to just sit up. And there we have it. The left side malleolus slips shorter than the right. Okay, so now we're going to move on to METs with Leonard. They stand for Muscle Energy Technique. The aim of this exercise is to initiate contraction of the extensors of the hip, helping therefore bringing that posterior rotation back in that left innominate. So what we do is we bring Leonard up into 90-degree hip flexion and knee flexion. He then uses his heel to push against my chest. And we want him to contract his glutes and his hamstrings to try and bring that leg down to the floor. So Leonard, if you push against me now, so 5, 4, 3, 2, 1, and relax. Then as he relaxes, we just want to initiate more hip flexion. This hip flexion will also initiate a posterior rotation of that innominate. And push against me again, so 5, 4, 3, 2, 1, and relax. So another treatment method that we're going to use with Leonard is a hip distraction with added hip flexion. This is a treatment technique commonly used for clients presenting with an anterior innominate rotation on one side. And the idea of it is that we bring the hip into flexion to initiate that posterior rotation of that innominate, that normative motion that we want back. And we're going to use distraction, which is good for helping relax all the surrounding muscles around the innominate, which may be contributing to its fixed position in that anterior position. So what we do is we just get Leonard to flex at the hip slightly. So therefore we're initiating that, like I said, that posterior rotation of the innominate. And we just want to add a distraction. We want a nice firm grasp on his heel, and we're just going to use a bit of distraction. Leonard can also hold onto the bed at this point, so he doesn't slide far down it. And we want to get him to relax as much as possible. And to see if this had any positive effects, we would then want to retest the leg line sitting test to see if it helped. So here we have a before and after picture of Leonard's sitting line test. We can see that in the top two pictures we have the left leg longer in lying and shorter in sitting, and then after the METs and distraction displaying equal length of malleoli on both legs in sitting and lying, showing that it had a positive effect. Now we're moving on to FMR of Leonard. We've used distraction in the local to the hip to try and initiate that posterior innominate rotation, which did help. So the sitting and lying test did improve there. So now we want to reinforce that space that we've created and use motion to bring Leonard into that space. We're going to use a form of FMR where we want to slow down the femur and also initiate that posterior tilt of the innominate on this left side. So if Leonard has stepped forward there anteriorly, I'm just going to place my hand in front of the femur here and a hand on the back of the pelvis, and I want him to come back. Then as he moves onto that front foot, we want to slow down that femur and really push down on that innominate to get the posterior rotation. And what Leonard is slightly doing here is he's just trying to use the transverse plane as he comes forward to rotate to get that motion. So Leonard, if you could just concentrate on driving forward with your belly button there. So if we give the client a driver, it can help him do the motion without having to think about it too much. So here's a summary of our treatment with Leonard. We used soft tissue treatments in phase 1 local to address the symptomatic tissue and reduce overall pain, using research into neuromodulation and pain gate theory. As we moved on to phase 1 global, we found that there was an anterior innominate rotation using the sitting line test, and we had suspicions from the original objective assessment anyway, using palpations of the landmarks on the pelvis. And what we did in the phase 1 global is we reverted back to some local treatments to the area. So we used METs and distractions to bring back that posterior innominate rotation, therefore giving us authentic motion back. The thing about treating clients is that you shouldn't always have to follow the exact protocol. In this video we are looking at phase 1 local and global,
but in the global assessment we found some malfunction in the pelvis. Therefore it's acceptable to go back to phase 1 local, treat the local area, and then we can then use FMR techniques or other to move into that movement that we've created, with the whole idea of bringing back authentic motion throughout the body, so everything flows as one and the person can move pain-free, especially in activities for Leonard such as rugby league. So guys, I'm afraid we've come to the end of vlog number 2. Joseph Westbrook signing out here. Have a great day and an even better Christmas. Happy holidays.